Okay, this video is about antidepressants and depression. Just a quick anatomy. This is a neuron. Here's the cell body. So this is the axon hillock. An axon potential is transmitted along the axon down to the axon terminal, and then NT here is for neurotransmitter. It will then pass to the membrane of the presynaptic neuron. It'll then merge with the membrane and it'll release its neurotransmitter across the synaptic cleft. It'll bind with a receptor on the postsynaptic neuron and exert an effect on the postsynaptic neuron. Okay, here's a picture of a serotonin neuron synapse. And so from this normal serotonin neuron, the neurotransmitter vesicle merges with the plasma membrane, releases its neurotransmitter into the synaptic cleft. It'll then bind the receptors on the postsynaptic neuron. And you can see here there's quite a few of these receptors. Then the neurotransmitter has to quickly be removed from the cleft so that the neuron can turn itself on and off quickly. It'll pass up through this reuptake transporter. It's called a SERT, serotonin reuptake transporter. And it'll re-enter the presynaptic neuron. It can be cleaved and degraded, or it can be put back into one of these synaptic vesicles. Now here's a situation after a patient's been treated with an SSRI, a selective serotonin reuptake inhibitor. It'll block the reuptake into the presynaptic neuron, but then the presynaptic neuron will fight the drug. It'll try to compensate for the effect of the drug. And this will happen over the course of weeks. It'll start to produce more reuptake, serotonin reuptake transporters. Also, because the cells are able to sense when there's too much serotonin in the cleft, the postsynaptic neuron will downregulate its receptors. Over here we saw multiple receptors. Here there's only one in this example. In addition, it'll make less neurotransmitter. So the point is, there wasn't any proven neurotransmitter imbalance. That's just a marketing ploy on the normal initial patient, depressed or not depressed. But once the drug is given, now the synapse changes and things do change and become abnormal. And this is thought to explain why is there a delayed response to antidepressants, SSRIs or tricyclic antidepressants. Okay, a couple, now some of the text down here. By the way, if anybody thinks that there's something else I should learn about neurotransmitters or depression or something, I'm happy to take a look at it. You can write it in the comments or something. I'll take a look at it. A lot of what I'm talking about here is going to come from this book, Brain Disabling Treatments in Psychiatry. I think this is the best book for the psychopharmacology stuff. Bragan was a Harvard-trained psychiatrist. He's sort of like what McDougall is to nutrition. Pathophysiology of the human body. He's sort of like that to psychiatry. A guy who's real smart and tells you the truth and who's reviewed all the literature. Okay, neurotransmitter chemical imbalances are a marketing ploy. They have not been proven for any common psychiatric disease, according to the opinion of many experts. Now, there's some who claim that there's new information, like this book was written in 2008, and I've seen some lectures online where some researchers are saying, oh yes, there is a excess of serotonin autoreceptors. Maybe. Those are disputable things that are kind of new. But, maybe something will come out to that effect, but it hasn't come out yet in a convincing way that I'm aware of. But here's something I thought was rather interesting, amusing. Okay, the big hot thing I've seen now in the psychiatry lectures on depression is this idea that perhaps the primary neurotransmitter abnormality is glutamate. And maybe dopamine and norepinephrine are modulators of glutamate. Glutamate is by far the most common neurotransmitter in the central nervous system, in the brain. And that, psychological stress leads to increased glutamate transmission in the hippocampus and some other areas, leads to lowering of GABA, that's an inhibitory neurotransmitter, and it causes a lowering of BDNF, brain-derived neurotrophic growth factor. And that this is thought to be associated with hippocampal atrophy. And you see why I'm smiling? Did you get it? I don't know if you've seen my earlier lectures on food and mood, because there's lots of things you can do to lower your hippocampal glutamate. And, the smart move would be do all that stuff first. There's a whole bunch of things you can do to try to improve the prognosis in a patient with depression, and they have no side effects. Why not do all those things first, and then If you still need more help, consider doing other things, okay? But for example, caffeine increases glutamate. It mimics acute stress, lack of sleep, another stress equivalent. MFG, manufactured-free glutamate. Aspartame, they all have a glutamate-like effect on the hippocampal neurons. Leaky gut, we talked about the Douglas-Kell theory in correspondence with dormant bacteria in the blood and LPS, and with elevated iron and ferrous redox cycling, all that stuff. So the only reason I mention is what I'm saying is when you optimize your nutrition, you're doing a ton of stuff to prevent excess glutamate, to basically do tons of beneficial stuff to yourself with no side effects. And that may also lower GABA. Get some sunshine, get your sleep, decrease your stress to the extent you can, get your exercise, increase BDNF. Plants have potassium and magnesium, lead to less activation in the glutamate synapses in the hippocampus. Spending time with your friends and family, people you love, having a sense of purpose, destiny, mission, meaning, religion for some, all of that helps you to be more resilient and to lower the stress level or stress effect in your brain. Okay, and then the other thing I say to myself, here we are, we're talking about all these fancy medicines, SSRI, selective serotonin reuptake inhibitor, SNRI, serotonin norepinephrine reuptake inhibitor, tricyclic antidepressants. Would these things even exist if there wasn't, big money in it, okay? If there's no money in this, would we even be talking about this? Would anybody even be promoting these drugs? I don't think so, okay? When you look at them, they worsen outcomes, okay, from my reading of them. And, make yourself sicker for what? Okay, you can talk to your friends or family for free. A lot of times that's helpful because they love you. They'll do the best they can for you. Sometimes that's not enough. Why do people get depressed? Bragan says, obviously it's multifactorial, but a lot of people are depressed. They have a sad life. People have disappointments, frustrations. They get rejected emotionally in other ways. Failure, loss of a loved one, a bad diet, head trauma, substance use. All these things can add up. It can be a medication side effect. So step one, fix what you can fix on your own like we were just talking about. Get to the people who you think might help you. And just try to make all the little things in your life positive. Each one might not do that much by itself, but they add up, the positive music, whatever it is, your hobby, your religion, your guide, your mentor, your role model. See if they can help you. Read about it, surf the web for information. Look at what your heroes did when they were sad, how they handled their failure, despair, and loneliness. Talk to a wise older person recommended by family or friends. Talk to a psychologist if you still haven't got it under control. Be careful about going to psychiatrists because nowadays psychiatrists tend to define themselves as biological psychiatrists. And I think that's kind of dangerous because what biological psychiatrist really means, it means prescribing drugs. And so if you go to a psychiatrist, you're probably going to be put on a drug. And according to multiple experts that I've surveyed their work, the more antidepressants you take, the more likely you are to have depression relapses. And the more likely it is to become a chronic thing. And with increasing relapses, you might end up getting sent for electroconvulsive therapy, or something like that down the road. So you worsen your prognosis. I mean, if somebody's at high risk for suicide, maybe there'll come a time when that's necessary. But there's actually a higher risk of suicide, according to multiple studies discussed here, in the patients who get the antidepressants than in the ones who don't. So what about all the stuff on the web saying, depression's so common? Some of that's just marketing. The more they can say it's common, the more they can justify prescribing more drugs. It's giant money. Antidepressant sales were $13.5 billion worth. Back in 2007, they're probably way higher than that now. The first SSRI came onto the market in 1988. Okay, then here's something. This was a quote by Friedrich Nietzsche. He lived from 1844 to 1900. And what I'm getting at is when a person, comes up to you and they're really sad, the first response should be, what's the matter? What happened? Give them a chance to talk. Try to understand them. Sometimes a person just needs to talk through a problem. It helps them to think clearly. It makes them feel respected and appreciated that you give them your time to listen to them. And the point I'm making is immediately saying, you're depressed, take this drug. There's something cold and, wrong about that. And here's just this quote from Nietzsche. And this is with regard to music, but there's something similar going on here, I think, in medicine, this cold, overly scientific approach. Nietzsche says this about music. A scientific interpretation of the world, as you understand, might therefore still be one of the most stupid of all possible interpretations of the world, meaning that it would be one of the poorest in meaning. This thought is intended for the ears and the consciences of our mechanists, who nowadays like to pass for philosophers. And they insist that materialism is the doctrine of the first and last laws on which all existence must be based as on the ground floor. But an essentially mechanical world would be an essentially meaningless world. Assuming that one wanted to estimate the value of a piece of music according to how much of the music could be counted, how much of the music could be calculated or expressed in a mathematical formula, how absurd would such a scientific estimation of music be? What would one have comprehended or understood or grasped about music? Nothing, really nothing of what music is would be explained by that. And that's kind of like trying to say a person's just a mechanical, lab animal with a disease, take this pill. That doesn't work either. Okay, just a quick summary. So MAO inhibitors hardly ever used. TCA, tricyclics. We talked about SSRIs. SNRI is just serotonin, norepinephrine, so it blocks the reuptake on another neurotransmitter. Sometimes you'll see stuff written as NSRI like this. When this epidemiologist in 2004 went through a bunch of studies on the use of antidepressants in pediatric patients, they're giving these things to kids. They had a 2.2 times increased risk of suicidality. So the point is, and very little benefit in comparison with placebo, it's making the patient worse. And this is what I mean by overemphasis on scientists with no love in it, and then everything going for money. You get all this stupid stuff, giving somebody a pill that makes them worse, and it's known that it makes it worse. No one should abruptly withdraw if they're on antidepressants, and I'm just giving you information. I'm not your doctor. I'm just teaching about this subject. A person should not abruptly withdraw from an antidepressant because that can be dangerous. There can be a lot of side effects. That needs to be supervised by a physician. Another thing is when you read the literature on antidepressants, what you'll find is tons of studies were done with bad results, and they just never got published. So, a company that's trying to market a drug wants a good result so they can get the drug approved and sell it, or sell more of the drug. So whenever it's a negative study, a lot of times efforts will be made to not publish the results. We'll talk later about that. There was a PhD scientist named Kirsch, and he went and got all these unpublished studies, and he's like, holy crap. The antidepressant drugs look far, far worse. In the unpublished studies, lots of really poor outcomes, and that's not widely known. Breggin claims that antidepressants have major, obvious side effects, but it's difficult to show any benefit over placebo. You have a drug company statistician trying to set up the study any way possible to make it look good, and they still can't. Hardly ever, make it look good. And the benefits, once you go through the details of placebo, you see minimal, if any, benefit over placebo. Breggin claims that the SSRIs also have, even more side effects than the tricyclics, more of a ability to produce an activation. He calls it a stimulant-like syndrome, and that can lead to restlessness, agitation, anger, hostility, insomnia, suicide, violent behavior. And you've all heard a lot of these people behaving crazy in public. A lot of them are on these pills. Okay, antidepressants and depression. Breggin says real-life suicidality is actually much worse than what is found in the clinical trials because the clinical trials are set up to minimize that. They're usually only 4 to 6 weeks long, whereas in real life, a lot of these patients are put on these drugs for life. Suicidal and psychotic patients are excluded from the studies, so they're really sort of a healthy cohort that goes into these studies, unlike in the real world. The studies are designed by the company to promote the drug. The data is collected by persons who are paid for by the drug company. It's in their interest to make that drug look good if they ever want to be hired again. And then the decision on whether or not the study gets published at all is usually made by the company as well. So this is a company-dominated literature. And not uncommonly nowadays, a lot of times the company will own the journal. And it'll own the reviewers. It'll own the editors. So, it's hard to get good information in a lot of the journals. Bregan claims that basically American children are being drugged with toxic antidepressants that have no proven benefit, that increase the risk of suicide, and can have major, serious, life-ruining complications. Tardive dyskinesia, suicide, and other problems. Okay, some of the more common side effects are just listed here. We talked about that stimulant-like syndrome with the SSRIs leading to violent behavior, increased risk of suicide. And so, this increased risk of suicide on the SSRI, the drug is causing increased suicide risk. That's exactly what it's supposed to prevent. Okay, SSRI is increasing the rate of suicidality. It kind of reminds me, like in the nutrition world, you see somebody recommending olive oil and lean meat to prevent atherosclerosis. There's no such thing as lean meat. The so-called lean meat at your best, maybe about 25% fat, which is really fat. So what I'm trying to say is there's a lot of people selling bogus information out there, so you got to be careful. That's why you got to be, your health is so important. You have to learn something about it if you want to stay healthy, because otherwise it's very easy to get tricked into nonsense. When one reads the standard medical textbooks, medical student textbooks, and a lot of modern pharmacology literature, you'll notice it once you start to understand it. There's an incredible effort to hide the real causes of disease, which is quite often diet and toxicology, and then to promote drugs. Okay? Let's see. Future generations will look back on our approach to chronic disease as incredibly ignorant. Like we said, all these things designed as chronic diseases, that means they never get better. Diabetes, hypertension. But the reality is, low-fat vegan diet, low-sodium vegan diet, hypertension often is resolved. Diabetes type 2 is often cured. And like we're just pointing to, it could also help these depression patients potentially a great deal. I'm not aware of a study, but all the information points to, I'm aware of a whole bunch of anecdotal stuff. People's moods improve, they become more calm, et cetera, less impulsive, but not of a specific study using it to treat patients with depression. I think that would be worth doing, focusing on lowering glutamate with all these dietary approaches and toxin avoidances, but I'm not aware of one really being done that way. Very few people are aware of stuff like glutamate synapses and stuff. Very few. And I mean people who you would think are aware of it, they're not. It's something I'm very aware of, so I was looking around for people who are interested in it. It takes a major effort to find useful information on that subject. But one of the reasons why I studied all this stuff about antidepressants and all this stuff is because I wanted to dig through the psychiatry and psychopharmacology literature to figure out what was known about it in humans. And actually, that was really useful to me. I just watched a really interesting lecture on glutamate psychopharmacology and its role in depression. And, that's sort of one of the big hot new things in the psychiatry world. And then again, why did I find it funny? Because you can make tremendous improvements on it by knowing this nutrition and physiology stuff. And it's still not going to be something probably you want to go down the path of taking a drug for. All right. Like I said, a lot of the stuff's not in the main books. Psychiatry is not only, stigmatizing these patients with a label, but they're giving them pills that don't work. That's not good, And I also say to myself, why are so few psychiatrists, trying to make things better? Because of the money. I mean, come on. Bregan's real smart. These other people are real smart. Grace Jackson, Kelly Brogan, Irving Kirsch. And it's also why I say, too, medicine has to have love. I mean, why do you want advice from your parents? Because they love you. They'll give you good advice. So they'll do the best they can. And even when they're wrong, you know why they're wrong, and you can adjust based on it. So I think that's important. Science without love, you end up with this type of stuff. Person goes and they're given a pill that makes them worse. All right, what is the mechanism of antidepressants? I showed on that one slide with the, the adaptations of the postsynaptic and presynaptic neuron. These page numbers are all from the Bregan book. So if anybody wants to look this stuff up, it's pretty easy to look up. Brain Disabling Treatments in Psychiatry. It's an excellent book. Bregan's real 1, 2, 3, 4, 5 in order. These are the issues with psychopharmacology, okay? So for somebody who's kind of new to reading about the subject, you might want to start with something like this, Anatomy of an Epidemic, by this guy Robert Whitaker. It's a good book, and he's a real good writer, clear. He's got a whole bunch of videos online. You can watch them. For fun, you can check out Kelly Brogan. She's a little crazy, but she's nice, and she'll do the best she can to help you. She's real smart, too. I'll show you one more book, too, that I've read that I thought was very interesting. It's by this lady, Grace Jackson, called Drug-Induced Dementia. She's real smart out of all of them. She's actually got the most creative mind, and she's trying to understand, why are all these people becoming demented? It's kind of like me. And she does a good job of going through some of the pathophysiology studies. She reviewed all these animal studies and the effects of brain damage caused by all these psychiatric drugs, but her weakness is she doesn't know pathophysiology, like in the context of vascular disease. She doesn't know excitotoxicity. So there's a lot of stuff I know she doesn't know, but she's smart. She's good. She doesn't know nutrition either. So I find her very much worth reading, but that's where she drops off on what she can do. Let's see. We talked about Bregan, and also what I was making the point was, to a non-medical person, it must seem bizarre to them. How could doctors not know this? And the reason is, like I said, they learn all this sort of irrelevant stuff in college and med school, and then by the time they get done with residency, and then by the time they get in practice, they're exhausted, taking care of their families, commuting, working really long hours, that they don't have much time to read. And Bregan says most psychiatrists, in his opinion, are getting their information from drug company salespeople and from professors who are paid by the drug companies to promote the drug. And he says that's why they don't know what's going on. Most psychiatrists, in the opinion of Bregan, do not know what is going on with these drugs they prescribe. And they have this unrealistic, overly optimistic view of them. And you would say, well, how could that be? And I know that that's actually kind of a common thing. I had the experience, I really wanted to understand diabetes. So I read all these biochemistry papers, all these epidemiology papers and stuff, and I wanted somebody to talk to. I didn't have anybody I could talk to about it. So I sought out some experts at a local university, and what I found was none of these endocrine doctors specializing in diabetes had read any of the papers about diabetes. I couldn't believe it, but I didn't meet a single one who had read the papers. So they really couldn't even have a conversation about something they treat every day. So anyways, anybody wants, all these videos are available at my site and, a lot of other places on the internet. It's hard to find good stuff. I try to put only good stuff on my site. Kelly Brogan, I told you about her, real pretty Irish-Italian lady, real smart, a little bit crazy. On her home webpage, she's got pictures of herself pole dancing. A little bit unusual. But she's clever, she's friendly, she's on your side, she wants to help you, she's nice, so you can learn some things about her. I don't agree with a lot of her nutrition advice or some of her other things she talks about, like coffee enemas or something like that, but I can just tell you, you listen to her, you like her, she's real straightforward and easy to understand. Okay, Grace Jackson, she's the one who wrote this big book, and she's got all these pictures and images from summaries of neuropathology, autopsy studies in humans, autopsy studies in animals, and she's trying to classify all the forms of neurodegenerative disease and all the mechanisms. I like her. She's like a female version of myself. She also reminds me like of a Pritikin. But like I said, she don't know nutrition, and that's what holds her back. But she's still really good, and I enjoy reading her stuff. Kind of a much bigger picture of all neurodegeneration rather than Bregan is neuropsychopharmacology. Okay, Bregan's really smart, obviously. Whitaker, his book here, he's real good. He's got a bunch of Anatomy of an Epidemic. He's got a bunch of online videos, real clear, gets to the point, really good writer, and he summarizes things like, back in the 1940s and 60s, depression patients used to get better right away on their own. They were fine. They didn't need any medicines. They get on with their lives. Most of them never had a recurrence. Well, he said about 45% had a second episode. Only 15% had 3 or more episodes. But most of them just got on with their life. And if you have 2 episodes, then you get on with your life. So what? You're fine. And he was talking about really severely depressed people. So depressed, they had to be hospitalized. And they still had incredibly good results of just spontaneous recovery. So it's a disease which perhaps is best not treated other than close early supervision to avoid a suicide. Nowadays, Whitaker points out that people are getting depressed at younger ages. They get put on medications, and he calls this a medicated depression, with more frequent relapses. The relapses happen sooner, and many of them end up on lifelong antidepressant, chronic psychiatric patients, relatively poor outcomes. He also points out that here's some trial that Whitaker reviewed the data from it, and he said the patients treated with antidepressants in this particular trial, was a big one in 2010, had incredibly bad results. It was an embarrassment to publish it. They had only 3% remission rate for 12 continuous months. Okay, that's incredibly bad. So it really doesn't even matter what the latest psychiatric theory is for these drugs. Their outcomes are terrible. Not even bad, terrible, okay? And here's the joke. The treatment's worse than the disease. Whitaker gives very nice, elegant descriptions of what's happening and what they believe with the synapses, how the synapse keeps modifying, and eventually that'll potentially become irreversible, and it'll be harder for that patient ever to come off the drug. And Irving Kirsch had made a comment that he's a really smart guy who did the epidemiology comparison with the Plato's placebo studies. And Bragan points out the same thing, and Whitaker points out the same thing. The more a person gets medicated for this, the more likely it's going to be a chronic problem with relapses, recurrences, and potentially lifelong staying on a medicine. So that's why, sometimes maybe if somebody's real high risk to suicide, they might need to be hospitalized, observed closely, but taking the pills would be a last resort from what I can tell about it. I'm not a psychiatrist. I'm a neuroradiologist primarily. I don't prescribe drugs, just so you know. My father was a psychiatrist, and like I've said that before in some of my other videos about psychopharmacology, my dad meant well, and he did the best he could, and I know him, and patients really liked him, and they would come to our house all the time. But what had been said by Whitaker, for example, and some of these other ones, is that, and Bragan too, lots of these patients, because they're getting better on their own, the psychiatrists often think that the drug got them better. No, it just gets better on its own. So it's a mistake to think that the pill did it, and where they put them with an active placebo, that means a placebo with side effects. Let's say it causes dry mouth. You can't show significant difference between the placebo and the drug in terms of beneficial treatment of their depression, lessening of their symptoms. For a new person wanting to kind of learn about depression and antidepressants, a good place to start would be Robert Whitaker and Irving Kirsch, their books or their videos. Then you want to go to Kelly Brogan. She'll give you a real friendly introduction to a wider variety of topics. This book by Bragan, it's a little more challenging to read, but it gets right to the point about the drugs. It's just, it's about pharmacology. Grace Jackson's book, big honking book. This is the best book if you're like wanting to try to understand the brain and how it works and what are all the different theories of brain damage and neurodegeneration. So she's, clever and interesting and sort of original in her thinking patterns. Okay. And like I said, do the antidepressants work at all? And Irving Kirsch, who got all the unpublished studies, and when you get right down to it, there's no clinically significant difference in the benefits from the antidepressants according to multiple studies. Bragan says the antidepressants are not only dangerous, they're also useless. Oh, there's another psychiatrist, Joanna Moncrief. She's got some good lectures online and whatnot. She's kind of a famous, I think she's from England. Okay, here's just a little bit of information about Irving Kirsch. He's got a bunch of online videos about depression. He wrote this book, pretty famous book, Emperor's New Drugs, about the antidepressant myth. He does extensive research comparing antidepressants to placebos. Okay, and then just to summarize my opinion, like I said before, patients with no medications, they tend to have better outcomes, less likely to relapse, fewer side effects, and all the things you can do to minimize glutamate and whatnot. So, well, let's see, I got maybe one more slide here. Oh, just on this last slide here is, here's the references. Here's some of those books I talked about, some of the research papers. And then there's, if you read these actual books, all these books will have tons of research papers for you to go through. And, you can spend a month all day long just reading about this stuff. But the bottom line, it comes down to the antidepressant pills don't work very well, and they cause a lot of side effects, and they increase your risk of relapse. So I'm not too impressed by them. Anyways, I hope that was helpful.